and will directly attack the next presentation and called Dr. Fadi Tannoury from Lebanon to talk about ablation of renal cell carcinoma.
Well, thank you. I have good news, especially for the French-educated guys here. Even if I want to try to speak as quick as Michael, I won't be able to do it, so enjoy my weak English. My talk is about ablation of renal cell carcinoma. And, well, I thought, rather than talking about and focusing on the technical point of view, I thought it would be more interesting to discuss the overall medical management of these patients, because I think this could be useful for convincing our clinician sending patients for ablation. So as we all know, this is the most common primary kidney cancer. 20% of these patients will present with metastatic disease, and 2% of them will present with bilateral metastatic disease. There is an increasing incidence of early stage detection lesions, mainly due to the widespread of medical imaging. They are divided in two groups, the benign ones, mainly represented by oncocytoma and angiomyolipoma, and the malignant ones, mainly the conventional RCC, but is also the papillary, the chromophobe, the collecting duct carcinoma, and the medullary carcinoma. Some of them are still unclassifiable. The prognosis depends on the size, the localization, the type, and on renal function. So this will lead us to the staging, which is mainly based on the tumor size, the vascular invasion, the lymph node invasion, as well as the local extension and the distant metastasis. And this slide clearly shows the correlation between the stage and the survival rate, estimated at over almost 95 and 91% respectively, for 5 and 10 years follow-up in the early stage. This percentage will drop below 20% in the unresectable cases. Duchenne published in 2003 a correlation between the pathologic findings and the tumor size, and demonstrate that there is almost 20% of benign lesions for small sizes. This percentage dropped to 0 when we reach 7 centimeters, which means that we can be we can be more aggressive with we have to be more aggressive for the larger size than for the small tumor size. Another published data comparing the histopathologic findings of the cortical early stage tumors, showing that the majority of them was conventional RCC. Those cases present 12% of recurrence rate at 5 years, and the other tumors doesn't show any recurrence, which may be partially due to the low metastatic potential of the other type of tumors. What about the renal function? It is well established that the morbidity is clearly related to the decrease in renal function, especially the cardiac disease, including the myocardial infarction, the coronary heart disease, and the sudden death. So this situation probably was one of the major factors that pushed the surgeon to perform partial nephrectomy than the radical nephrectomy, which has been performed earlier. And this study clearly convinced us that partial nephrectomy is very important in preserving renal function and nephron capital. So we can discuss right now the fundamentals of renal cortical tumor management. So as we said, if we have small tumors, we have 20% of benign lesions. 30% of them are early stage with a low metastatic potential. So the standard surgical treatment is responsible for an increasing risk of developing chronic kidney disease. And if we reach a stage 3 chronic kidney disease, this will end up with 20% increase in risk of death and 40% increase risk of cardiac events. So the key point here that we have to convince our clinician about it is how to save the kidney function, because this is the most likely to impact the survival. So saving the renal function, we have 3 opportunities available right now. We have the active surveillance, We had the partial nephrectomy, either by open surgery or laparoscopic surgery, and we have the minimal invasive technique. The data currently available suggesting that minimal invasive technique are available for treating early stage renal cell carcinoma include the radiofrequency ablation and the renal cryotherapy. The other modalities are interesting, promising, but we don't have data available yet to support their use. Active surveillance could be proposed for single small cortical tumor, as we know that the majority of them would be benign and they have a low progression over years. And they propose to do the resection once the lesion would reach 3 centimeters. On the other hand, the disadvantages are that we don't have any predicted outcome about the metastatic potential of these tumors, and it needs frequent surveillance, which will lead to anxiety, and the majority of the patient would refuse this attitude and prefer to get an excision of the lesion. Concerning the other approach, talking about open or laparoscopic partial nephrectomy, well, this data is very interesting, comparing the same number of patients with almost the same size of tumor, and as well as the same percentage concerning the localization of tumors. So it is quite a homogeneous study showing that the laparoscopic approach is better than the open surgery, mainly in analgesic requirement, hospital stay, convalescence, and in total, the post-operative cost is also lesser than the open surgery. So the laparoscopic partial resection is considered right now as the gold standard of care for these tumors. Another data is support the laparoscopic surgery than the open surgery is the renal recovery after open or laparoscopic surgery, showing that the renal recovery is much easier and better after laparoscopic resection. So the thing that we have also to keep in mind is the complication rate and percentage associated to surgery. This is also a tool that we can use to convince our clinician about about using ablation. I'm not going to go through all this, but just to say that it's not as rare as we can think. So for percutaneous ablation, this is a very interesting tool because you have the nephron sparing, of course. We have low complications rate comparative to surgery, low morbidity, and it can be done as a one night stay only, but it still have some possible risks. First, that if there is any tumor left in situ, the only control that we have for the good resection is the absence of enhancement on the CT or MRI, but we are not sure about the secure margins after resection, and we don't have a long oncologic, long-term control is still unknown. There's some specific consideration about renal cell carcinoma ablation if you compare it to liver. We have the anatomical localization, which is maybe very tough to deal with, especially in the anterior localization and if the lesion is very central. The other issue is the high risk of adjacent organ, which might lead to heat injury. And the third risk is the heat sink effect. It is higher than liver, and this is due to the high perfusion organ. As I said, the anterior and central location are associated with a low success rate, probably because we are afraid to do 2 sessions during the ablation, and this is mainly because of the risk of collecting system injury or vascular injury. The size is also very important, and we have to keep in mind that not only the heat sink effect is responsible for the recurrence, but we published this last year in the CIRSE in saying that we have also clearly a heat dissipation once the tumor exceeds 3 centimeters. So if you are dealing with a tumor above 3 centimeters, you would probably better do multi-sessions ablation than 1 session to get a better outcome and a lower recurrence rate. The CT scan is the best modality to perform this procedure, a fluoro-CT would be very helpful, especially to make sure not getting close to the adjacent organ that we talked about earlier. There's some tricks to overcome this kind of complications. There's the cold pyeloperfusion technique, which has been proven to reduce the risk of chronic structure in the collecting tube. And there is the hydrodissection technique, which has been used a long time ago, and it is well known while treating liver metastasis, especially in segment 5 and segment 6. So we have to make sure if you have a close organ, an organ close to the tumor, we have to make sure about the localization of the tumor, if it's anterior, and make sure also if we don't have enough thickness of abdominal fat, minimum 5 millimeter required. The heat sink effect, as we said, is higher in tumor ablation, and this is mainly due to the hypervascularized organ, which will necessitate repeat sessions, and especially if you have a delay impedance rise, and if you have a lower temperature during or after the RF ablation, dependent, of course, on the probe you are using. So if you compare the results of FA and cryotherapy, doesn't look very clear. The results are excellent, as we mentioned before. So we have, and they are similar, and some data have been published comparing cryotherapy to radiofrequency ablation, and they were in favor of cryotherapy. This was based because the cryotherapy was performed in the open surgery procedures. So it wasn't really a good comparison between the two techniques. Nowadays, we can consider that both techniques are equal in results and in rate of recurrence. What about the complications? Well, there is the post-ablation syndrome, which is which include the radiofrequency ablation and the cryoablation, and it is self-limited symptom. We have the mild hematuria, which is also in the majority of cases self-limited. The pain and the paresthesia is the most common symptoms at the skin puncture site. We can have bladder obstruction due to clot, and this can be treated by irrigation. And the periphrenic hematoma, majority of cases are also self-limited and treated symptomatically, but we have to, some tricks like doing ablation while retrieving the electrode in radiofrequency or injecting some gel foama after cryotherapy. Thermal injuries, well, it would include the ureter, which may lead to urinoma, ureteral stricture, the genitofemoral nerve injury, and this will be responsible of chronic pain of the ipsilateral groin, the psoas muscle injury, which is responsible of hip flexion, and the most serious complication is the small and large bowel injury. And this is why we have to be very aware before starting the treatment to get really a secure margin with a good hydrodissection, avoiding this complex complication. The injury of the adrenal gland has also been published and may be responsible of hypertensive crisis. There is no consensus nowadays concerning the follow-up. The majority of the teams are performing immediate CT scan, 3, 6, 1 year, and once a year after that. Areas of enhancement, more than 10 Hansfield unit or more than 15% on MRI is considered as a recurrence. And in cryoablation, the thin peripheral rim that we might see is usually seen several months later after the treatment. Concerning the microwave thermotherapy, there is no significant clinical data right now available reported supporting this technique in the treatment of RCC. Irreversible electroporation, this is a very promising technique since it doesn't use heat for ablation, and it will probably find its place, especially in the central localizations. For focused ultrasound and intercavitary photoirradiation, I think that it is too early to confirm the results with this kind of treatment. So in conclusion, extensive clinical experience support nowadays the role of radiofrequency ablation and cryoablation in the treatment of early stage RCC, especially in patients who are at high risk or in patients that they refuse to undergo surgery. Both radiofrequency ablation and cryoablation are well-tolerated procedure, and they have demonstrated acceptable short and mid-term outcomes. Patients at risk of, for renal compromise may undergo this procedure effectively with preserving of the renal function. Thank you.
Thank you, Fadi, for this nice review and presentation. Can I have the mic, please? This work? Thank you. Thank you for this nice presentation and review. Actually, this was very helpful. We have, I think, 5 minutes for questions. Before I introduce Dr. Kalekis, I'd like to inform you that Dr. Jens Ricky will be giving his lecture right after Dr. Kalekis, and he promised to shorten it down to 15 minutes. So beyond that, we might have few minutes for question before the break, and we might restart back again at 3 p.m. to stay on schedule. Any questions? Go ahead.
Excuse me. Do you obtain histologic proof of malignancy before the session of ablation or the same times?
Well, tumor biopsies has largely debated before the percutaneous ablation. But nowadays, of course, the biopsy is performed during the same session, and it is important because, as we said, the type of tumor is important to know. I mean, giving the survival rate and the rate of recurrence. Yeah, of course. So we perform the biopsy during the same procedure.
But if the specimen is equivocal, we will have not proof of histology. So many authors advise to perform a biopsy separately before the session of ablation.
Well, this
especially in some cases of lymphoma, we can change the treatment to give.
Well, it is really debated concerning performing biopsy before the procedure. There's plenty of published data talking about that, and we discussed. I've been through it many times, and the majority of the surgeon would say, well, if you do your biopsy and you would say, well, you don't have any malignant cell, he would not take the risk with, not taking off the tumor and waiting for the metastatic stage. So it is largely debated. But what I'm saying, once we decide to do it as percutaneously, we perform the same biopsy and the coaxial approach. So we have histopathology before performing the ablation.
Thank you, Fadi. Dr.